Afternoon, everybody, and welcome to the breakout session on making success sustainable, the extended roles in primary care. So we're really fortunate to have 4 speakers this afternoon, and then we'll be having the opportunity to ask any questions. So I will ask people to either put their questions into the sidebar, or there'll be an opportunity to put your hand up later and ask any questions of any of the speakers. So we'd like to start the afternoon by inviting Jane Wilde to do her presentation. So thank you very much, Jane.
I'll unmute. Hello, everybody. Hopefully you can see my screen and hear me. So thank you for the opportunity to come and talk about audiology in primary care in Wales. I'm doing this as a joint presentation with Nicola, Phillips and Swansea Bay University Health Board. So this is progress on from awards that BCU and Swansea Bay University Health Board have had, achieving Advancing Healthcare Award in 2018 for BCU in the Developing a Sustainable Workforce category, and then a finalist in 2019 at the UK AHA Awards in the Innovation in Healthcare category. And for Swansea Bay, a finalist last year in the AHA Awards for Leadership, Change and Management. And it just struck me how this scheme actually spans a number of categories and has been successful and recognised in those different categories. So first, whoops, the camera went off then, so bear with me. Next slide, I've pressed next slide, so hopefully it will come through in a second. We did have some technical problems just before the break. It's not going to the next slide. Would you be able to take over, Ellie, and put yours up? Just it seems like mine's not moving. Thank you, thank you. So I'll wait until I can see the next slide. I'll stop sharing. We knew that would happen. So I'll just wait for the next slide to come up. So next slide, there, brilliant. Okay, so what is first point of contact audiology in primary care? Well, there's 2 similar schemes, although not identical, in place at BCU and at Swansea Bay. So both move the audiologist further up the pathway and nearer to the patient, making them the first point of contact for people with specific conditions, so hearing, tinnitus and specific balance conditions. So historically, pre the 1990s, people with these conditions would present to their GP, who would refer on to ENT, who may or may not refer on to audiologist. In the 1990s, we across the UK really was embedded a direct referral system where patients, GPs could refer directly to audiology, sort of taking the ENT out of the equation with cross referral where required. But what this new model does is places the audiologist as the first point of contact in primary care. So replacing the GP consultation and with the audiologist being able to refer on to GP, ENT or audiologist as required. So next slide, please. The main aim benefit of the scheme was to release GP capacity. So freeing GPs up to see more complex cases. And that BCU data shows that about 74% of patients presenting to audiologists in primary care are presenting to the audiologist as the first point, not having seen a GP or a practice nurse before. Another key aim was to provide specialist care closer to home. So in both services, the data shows that majority of patients can be managed in that primary care setting, with only relatively small numbers being referred on to ENT and audiology and back to the GP, with similar data across both services. Next slide, please. There are a number of additional benefits. So we see more appropriate on referral to both audiology and ENT. And that's because we're enabled to do some diagnostic testing and information that follows the patient, making a more informed choice, but also informing the people we're referring on to. There's improved access. We know there's a known unmet need in this population. And what we've seen is increased presentation rates in primary care for these conditions. There's also greater control and choice for the patient. The patient can choose the professional they want to see. They have direct access to specialist care, and they can also re-access the service if their symptoms return. It is a truly integrated pathway with a service from primary right up to tertiary care across Wales. It's enabled a much more improved cluster working, getting to know the other professionals within the cluster and working closely with them, and thereby really raising the profile of hearing tinnitus and vestibular difficulties as important health conditions. Next slide, please. So where are we now? Well, both services have continued to deliver, albeit with a pause during COVID, whilst primary care went to essential or urgent contacts only, and whilst some staff were redeployed. But at BCO at the moment, we have 5.5 whole-time equivalent advanced practitioners who have seen to date more than 36,000 patients, and that's about 700 patients a month for this advanced practice element when we're at full capacity. And that's delivering in 36 GP practices, about 25% of GP practices across North Wales. We additionally have in one cluster an audiologist practitioner who is doing a slightly different role in terms of routine wax removal. At Swansea Bay, since the reactivation in January, they've seen nearly 5,000 patients in 5 clusters across 33 surgeries, covering a population of 225,000 people. And they're currently offering 50 sessions a week in primary care, a similar split between advanced practice and more routine wax removal sessions. And at capacity, they're seeing about 240 patients a week. Next slide, please. So what's happened since the award win? Well, I think it's fair to say that since the awards the last couple of years, progress has been slow in terms of rollout and progression. But at Swansea Bay, there's a full business case that's been developed that is being considered by the exec board in December this year, next month. And at BCU, I'm really pleased to be able to say that we've had full approval for our business case to roll out this service to all GP practices over the next 2.5 years. There's been varying progress at other health boards in Wales with business case development and various stages of approval. I think it's also worth mentioning as well, since the awards, there's been a national wax management pathway has been developed and was circulated via a Welsh Health Circular, which is a national pathway, but says that this should be led, managed and delivered by advanced practice audiology in primary care. And this pathway and this model features within business cases of both Swansea Bay and Betsi. So next slide, please. So lessons learned and the secret to success. Well, I think it may seem an obvious thing to say, but I think the value of the service is very much in their effectiveness. So being able to get the opportunity to start the service, evidence its impact and its benefit was really a key element of success. Until this point, it was an idea. It's completely innovative. It's not being done elsewhere in the UK or the world that we know of. So being able to try and test that model and collect evidence to show that it works has been really important. Secondly, the success to progress in the business case and rollout plans has been very dependent on sharing the vision and getting others on board. So this includes senior members of primary care teams, clinicians, cluster leads and GPs, as well as obviously service users themselves. Further to that, it's been about persistence, not giving up when meetings have been cancelled or your items been knocked off the agenda, and similarly, sort of embracing requests to adapt or change your business case, but really believing in the model that you're proposing and standing firm where you know it to be right. Alignment with policy always helps, and the Welsh Health Circular and the National Wax Management Pathway and other key policies really help to support the business cases. And finally, promoting the service, sharing what you are doing with others, professional conferences and via awards, and raising the profile to showcase what's being done have all contributed to success so far. Next slide, please. So the opportunities and challenged experience. Well, the opportunities have been and are still significant. We've now got a proven model that shows that it works, it's successful. We've got a model and we've got evidence of the benefit. We've got policies and Welsh Health Circus to support the model and its implementation. We have similar challenges within primary care workforce across Wales, so the opportunity in terms of making a difference there across Wales. And very importantly, we have audiology services motivated and ready to go and take this forward across Wales. And in audiology, we also have workforce plans in place that have been developed over a number of years to give us a workforce ready to see this growth in audiology across Wales. The challenges may be less in number, but are not insignificant. I think the key one, and I heard it from the session earlier on, it is about sustainable funding. You know, we need to get health boards to commit to invest in this scheme over other schemes. Other challenges are around awareness of the service, making sure that everybody knows it exists and of its benefits, and raising it across other health professionals. And there's been some other practical challenges around service delivery, for example, around IT systems and connectivity and information governance. Next slide, please. So finally, how can success be scaled up? Well, I think it's really important that we have a workforce plans in place to be able to produce the workforce we need. And that's not something we can do quickly or overnight. It needs thinking ahead. We might need to think differently, thinking about fast track schemes or ways of growing our own staff. But we also need to make sure commissioning is lined up with aspirations and plans. And we might also need to influence training schemes and the content of training schemes as well to make them fit for purpose. The other key thing is to raise the profile and work collaboratively. There's a huge value in sharing successes and materials and working with others and other disciplines across Wales and not reinventing the wheel. It's essential to share and collaborate with key people and decision makers in and outside of our discipline, sharing the vision and getting key people on board. And finally, I think we need to, the success is dependent really on a change in perspective, where we think outside of or across the whole health economy. Investment in audiology and primary care needs to be as a solution to free up GPs rather than just about an investment in hearing tinnitus and balance conditions. Thank you. I think that's it. If we've got any questions, more than happy. And there's myself and Nicola's emails there, but I will be on at the end to answer any questions. Thank you.
Thank you, Jane. It's been really exciting to hear the work that you've been doing in the innovative roles that you've been creating. And I know from Powys, we've been looking at what you've been doing with interest. So please post any questions that you've got for Jane in the chat, and we can come back to those later. And now I'd like to move on and introduce Nicola Phillips. So, okay, I think we might be moving on along the list. So I think next it's Jane Lewis. Is that right? That's right. It was joint. That's my mistake. Sorry.
Thank you, Claire, and thanks everybody for coming and joining this session. So again, like Jane was saying, I'll have a chat to you about the work that we've been doing, and then I'll be available for questions at the end. So I was one of the finalists in 2018, and the project title was Minimising Diabetes Foot Surveillance, Disparities Across Wales, and it was in the category for Outstanding Contribution to Research Delivery. The work was looking, as it says in the title, about the disparities of diabetic foot surveillance across Wales. So as a podiatrist, we're fundamentally involved with foot health care. A huge proportion of those are high-risk patients that do have diabetes. And we're very aware that whilst podiatrists are working as an all-Wales service, even in the 7 different health boards, not everybody comes under our care. So we're conscious that maybe not everybody is receiving the diabetic foot screening or surveillance that they should be having. So the project that went forward as one of the finalists was a collaboration between Cardiff Metropolitan University, which is where I am now, having spent 16 years in the NHS, with Public Health Wales, the eye screening department, which sounds weird when we're talking about foot screening, but you'll understand shortly. Cardiff and Vale University Health Board and CUMTAF. It was just CUMTAF Health Board when we did the project, but obviously they're CUMTAF Morgannwg now. Okay, so my slides aren't moving on either. Here we go. So as I mentioned, we were looking at potential disparities in foot screening. When I did my PhD a long time ago now, the professor that was I was under guidance of set up the eye screening for diabetic patients across the whole of Wales. So I looked at that model that's very successful and that's cut blindness through diabetes by more than 50%. I looked at that model as maybe a potential model that we could adopt for foot screening. Before I could get going with that, I did a time and motion study to see whether we could run the foot screening alongside eye screening. There's a 20-minute period where the dilating eye pupil drops are administered before individuals can have photographs taken of their retinas. And so I was looking to see whether we could shoehorn maybe in a foot screening during this time. So the time and motion study suggested that it could be done. So we picked two very busy clinics, one in UHW and one in Royal Glamorgan Hospital, to try this out to see whether it worked. It didn't need to be disrupting the eye screening. It would potentially long-term in my idealistic bubble would be one service. I'm not sure that will be possible, but certainly the two teams ran very well together. We found that it was incredibly popular with patients. It wasn't compulsory. It was an optional, opportunistic surveillance for them. 90% of those attending for eye screening that were eligible for foot screening took up the offer. We found that 12% had loss of sensation, so neuropathy in their feet, that hadn't had that diagnosed before. Patients suspected something was a bit different, but hadn't actually reported it to anybody. But the surprising thing was that over a quarter had peripheral arterial disease, so that's reduced blood supply to the feet. But were asymptomatic, so weren't describing or experiencing the normal symptoms associated with peripheral arterial disease. And we followed a number of patients up randomly by telephone, those that were happy to be contacted to see what their experience was like, and whether they would value this or welcome this as part of their routine screening in the future. And 100% of those that we contacted said yes, they would definitely, thought it was a no-brainer. So the suggestion was that by including this within an already successful screening or alongside an already successful diabetic screening model, we could potentially capture an awful lot more. We could identify any problems a lot earlier and therefore could initiate any management or potential advice on lifestyle choices a lot earlier. The trouble with preventative models is that there's not an instant cost saving. It would be 10 plus maybe years down the line. So that is a bit of an issue. And whilst we're fighting fires with foot infections and amputations and trying to cut the number of those down, there still are happening. So that was one of the reasons that I moved to the university, was that there was no time to look at prevention strategies necessarily with podiatry. It was all very much just trying to save limbs, which is still a massive job that we're trying to do. So if I just move on to the next slide. So what the lessons learned, hang on 2 seconds, I'm missing a slide, I think, of my own. Okay, no, I'll go back. Okay, so we're still always looking for new or innovative healthcare delivery models, and they're always going to be needed. So we always need to modernise our services. And I could see that there was definitely a flaw in this. How it was to be delivered, this is the bit that we didn't know, to get the consistency and to get the equity across Wales. Chronic disease prevention models, as I mentioned, they are really hard to prove in the initial stages. They do require some investment, financial investment to get going, and the cost savings potentially are not seen for some time, perhaps in excess of 10 years with diabetes complications related to the foot. But this is something that has never put me off, and I still keep striving towards it. And so probably that's one bit of advice. If you believe that there's going to be a positive impact on health, then don't be put off by the barriers that may jump up in front of you. You have got to produce evidence, as Jane mentioned. You've got to be able to provide the information that says it works, or it has the potential to work. You've got to believe in what you're doing and be passionate about it. And ultimately, you need to build the support network. And all of those together then will lead to your success. In this case, we're not looking for a quick fix. We're in it for the long term. And like all of these services, they need to be sustainable. But I think the most important thing is to get the support network built up around you. So what's happened since the awards that we were a finalist in? COVID, that's what happened. Everything stopped, particularly screening services or surveillance services. We know that COVID's had a huge impact on all of our health surveillance and a lot of treatment. We don't know what those effects are going to be long term, but we know there'll be something. So this again is another opportunity to rethink how we deliver services, and how we can perhaps find something positive to come out of this. We know we've got reduced face-to-face contact, so how can we look at things differently? And this project, whilst I'm building fantastic group of people, stakeholders to work on this together, is kind of ticking more boxes now, in that we're looking at combining surveillance services within one appointment. So patient comes in for eye screening, and then they get foot screening, they get urine analysis, they have potentially atrial fibrillation checks, which are a quick and easy thing that we've started doing in a lot of our podiatry clinics now. To be able to scale this up, you've got to make sure that it works. I went to Welsh Government to ask for their support. They were again saying it was a no-brainer and just do it. It's not as easy as that. We need to try it out and test it. I've only done it on a very small scale. The next step is to do it within a health board, one or two health boards, but on a bigger scale than I've done already, to make sure that we get that clinical pathway right before we then roll it out across the whole of Wales. But the support that I'm building, the stakeholders, the network that I'm building is an all Wales one rather than just locally. That's with cardiologists, with vascular consultants, with GPs, with pharmacists, with podiatry departments. Whilst it could be led by podiatry, it doesn't need to be a podiatrist that does the screening. But everybody needs to have a say in that and how it might look for it to work. I learned that from my PhD, that you get everybody in the room together, they all have buy-in, they all have their say, and you address all of that as best as possible. But ultimately you have an agreed pathway, and that way you've got a much higher chance of it actually working. Challenges, I think that initial one was Welsh Government saying go and do it, and the understanding that actually it's not as easy, quite as easy as that. COVID obviously was a challenge and still tends to be. The Wales eye screening service is still not up to full capacity. Probably about 4 months ago, they were still only at 26% capacity, and that's largely due to them losing vital screening sites for COVID purposes. These things take time to get pulled together, and the initial funding. So as I mentioned earlier, these preventative strategies, they do need some initial funding, which isn't always that cheap, but actually in the longer term, it will pay for itself. So it's convincing perhaps Welsh Government, going back to Welsh Government when we're ready to get going, to see if they'll support that. Opportunities, so with the big reduction in number of sites for eye screening, I had a chat with the management here at Cardiff Met University to suggest maybe we could offer our site, perhaps the Llandaff site where most of the health services, health courses are taught, as a possible screening site for eye screening and maybe AAA screening. And that looks very positive to start, not as soon as I would like, but certainly by next autumn. Opportunistic surveillance, so we're including atrial fibrillation screening now at Cardiff Met for our private patients, and we have funding to support a couple of other local projects in podiatry departments where they're seeing mostly high-risk patients or high cardiovascular risk patients to also do surveillance with them. And I think, you know, with this reduced face-to-face situation we have that COVID has put upon us, we need to make every contact count, which a lot of us know all about. And so if we can be doing more, let's do more. I know I'm working with some pharmacists too, who are also adopting the atrial fibrillation quick 30-second screening, single lead ECG screening, maybe when they're checking blood pressures. And so our pharmacists within GP practices looking to support them doing the same. Building working relationships now for support in the future, I think that's essential. If you can work with all stakeholders and have their involvement and their belief in what you can do from the word go, then that will support the service in the long term. So I think that's an opportunity that, even though COVID's kind of halted things, I've been busy trying to build those relationships to support the service once we can get it going. So how can success be scaled up locally and nationally? I think I've touched on that a little bit, but I think ultimately it's about the support. Don't think that it's possible to do it alone or in a very small team. I think Jane alluded to that as well, about outside of your profession, getting the support from other health professionals outside of your own profession, but also the public support and involvement. So any new studies or services that you're trying to develop, if you've got the public supporting it and involvement in designing it or disseminating it, then it's listened to a lot more. We're lucky in that diabetes has got a lot of PPI involvement locally, certainly. And they're always offering advice about what they feel other patients or people similar to them would like. And it just makes you think twice about things. But I think it's essential for things to work, is that it's all very well having an idealistic view in your own mind, but it's got to be acceptable to those end service users. Steering committees, again, essential to make sure everybody's got buy-in, and that would involve the public as well on those steering committees. Prove that it works on a small scale first. An example of where this has been as successful is a Public Health Wales, Welsh Government and Dietetics programme that's been tested locally, and this is for a pre-diabetes group where they have intense involvement with dietetics to try and prevent them developing full-blown diabetes. They tried and tested it locally, it worked, and now they've got support from Welsh Government to roll it across the whole of Wales. I think you've got to be adaptable in that you will need to make small adjustments because every health board is slightly different. Then it's not one thing, a bit like one shoe fits all, excuse the pun, but so you need to be not so I don't know, fixed on an idea that you can't be slightly adaptable to make it works in a different area. That's going to have to be accepted, and not be a big surprise if you need to do that, but that should be possible. And I would say, finally, don't give up. I think, you know, this clearly, for me, whilst it's not actually underway as yet, I still believe it will be. I've been working on this for years now, believed that it can work for a long time now. I still believe that it can work, and I still believe we will get it to work. COVID slowed things down a bit, but I still plan to keep pushing away with it, and I've got plenty of support now, so I can't not go ahead with it. So I think that would be my final thing. Don't give up. Thanks for listening, and obviously I'm around for questions if you want to ask any.
Thanks, Jane, for your talk. And I think it's a really great example of value-based healthcare. It really is looking at what we can do to make the best for patients in the easiest way possible. And it's probably really cost effective, as you say. So thanks so much for that. And as we've said before, please put any questions for Jane in the chat or ask them later. So the final talk that we're having this afternoon is Jeanette Starkey. So I'd just like to welcome Jeanette. Thank you.
Hello, I'm just trying to upload. Oh, there we go. Select PDF. Sorry. We'll be with you in 2 seconds. Hi, is that me live now? Hi. Hello, everybody. My name is Jeanette Starkey. I'm the Gastroenterology Dietitian Clinical Lead in the Wrexham Maelor Hospital in North Wales. So it's lovely to be here today to share our experience of setting up a project that our aim was to improve health outcomes for our patient group. So it started a few years before that. I noticed that by the time patients got to us as dietitians for functional gut issues, they'd been on almost a 2-year journey from GP to consultant, often to colorectal consultant, lots of invasive investigations, colonoscopies, endoscopies. So by the time they got to us, it was 18 months, 2 years down the line. We would do our dietetic management, and often the symptoms would get really good improvement. So it felt like an ineffective use of resources and time, but for the patient, it was a frustrating, anxious kind of process drawn out for them. So I set about thinking, well, we have to manage this better. And we created an Ibs referral pathway, and we involved a GP cluster lead, our biochemist consultant, and our gastro consultant. And our aim was to reduce waiting times to gastro consultants, really mostly for the patient journey, because they were, it was just an awful experience for them sometimes, and to help reduce their experience, their symptoms, sorry. Can you see that? I don't know whether you can see that. It's quite a lot on the slide, so I'll talk through it. So we were categorized a finalist in the award for improving health outcomes. And I think from the project, I was really pleased to see, I think we've done that for a lot of the patients. So we had a 40% decrease in referrals from GPs to primary care gastro consultants in the age 16 to 50 group. And alongside that, there was actually a 28% decrease in referrals in total for that age group. The GPs were screening much better. They had the pathway in use. They would do their bloods, their stools, and think, right, okay, the dietitians can manage them. We had a 23% decrease in the number of investigations that patients experienced, things like endoscopy, colonoscopy, sigmoidoscopy, some other blood tests. So lots of invasive procedures. And that was £134,000 saving over the 2 years from 2017 to 19. Now, when we compared that to, we've got 2 other hospitals in our trust who don't have this pathway in place, and one of them had a 2% decrease, which is great, it's still a decrease, but the other hospital had a 14% increase in endoscopies, colonoscopies, and sigmoidoscopies. So it's quite a disparity between a 23% reduction and a 14% increase without having dietetic input involved. So we also wanted to then look, how was it working from the gastro consultant side of things? Because obviously if you're going to move services forward, as we've heard before, it needs to be in conjunction with other people who are a part of the pathway. So we saw, of all the patients we saw, we discharged 91% of them without any involvement from the gastro consultant at all. So we would screen them, assess them clinically, nutritionally, and manage their symptoms that way, and we could discharge them. But I also wanted to make sure that patients weren't being discharged from us, going back to the GPs and then saying, still not quite happy, I still want to see a gastro consultant. So our re-referral rate back to the service was 1 and 5% at 12 and 24 months. So I compared that to a piece of work that was done for a very similar setup in Australia, and they had the same referral rates. And when you referral rates. And when you compare that to, say, the patient had seen a gastro consultant, had been discharged, what were their referral rates? And that was similar to the dietetic ones, about 2 and 6% as well. So we're really pleased with that. The patients had enough improvement that they didn't want to be re-referred back to the gastro consultants. You can also see we managed to get patients off or reduce their medications. So we had a medication save then. And 80% of our patients had good to really very good symptom improvement. So which was one of our drivers really to make their experience better. And then from a cost point of view, which I know health boards are always interested in, total of that with consultant versus our time, reduction in investigations and medicine spend, for 2 years, we saved £200,000 approximately. So what lessons did we learn? So it's going to echo probably a lot of what our other speakers have said. So at the moment, I'm now looking to set up another service. I reflected on kind of what things am I doing then to now to make it push through. So the main things were, for me, having a really clear vision of your service, both as us as a dietetic team, but as part of our broader medical team, therapies team. I really strongly believe, you know, we're not an add-on service when in terms of the patients seeing all the different doctors and then we don't know what else, then send you to the dietitian. I really believe we're an integral part of the team, an integral part of service management for the patients. So I thought having the confidence in that and believing in that, it's one thing to say it, but I think, as somebody else has alluded to, you have to be able to demonstrate that. So we, as a team, have always worked towards increasing our scope of practice, and we could demonstrate our increased clinical knowledge and skills. So our team, which is what made the project a success, had confidence that we could come in, assess patients, order various tests, interpret them, and the patients would remain safe based on our clinical decisions. Again, communication, again, a common theme throughout the talks, is really being able to express your ideas clearly and the benefits they bring to your service. You do have to go out and meet people, network. Some people are great at that. It's not my natural forte, but I do it because it's a have to. It's the only way you can get people to buy into your vision. As you said, you can't do it on your own. So where I approach that is creating a longer term kind of build up of relationships, looking at people who I know have influence, who are the decision makers, who are interested in what we do, and then linking with them, build that relationship over a period of time. So when there's opportunities arise, you've kind of got a team who are on board with you, you've got agreed goals and shared vision for a service. And again, persistence, as we've said, I think it's don't be afraid of the initial no that you might receive. You know, it's not personal. It can never take it personally, I don't think, if you've done your work and you believe in your model. Sometimes the timings are wrong, funding's up there. I go away and I think, well, do I need to rethink how I've delivered something or communicated something? Often there's really strong held beliefs within a service about what should be done, how and by whom. And so it's working towards changing attitudes around that. And for me, finally, the main thing, which I couldn't have done it without this, is your data collection, which has been the main driver for change. You've got to collect those numbers. I know it's not always exciting at the end of a busy clinic to put them into the database, but without that, we wouldn't have been able to prove anything in terms of our value, our worth, and where we see the service going. So what's happened since then? So we submitted business plans, and we've had some real interest across our therapies directorate in terms of trying to roll our vision out because it's worked so well in our hospital. And recently we secured some funding, referral to treatment time funding, to trial a dietitian first gastroenterology clinic, which is a little bit different from the IBS clinic, whereas the GPs, they do their assessments or their screening, refer to us, or we'll do it if they haven't done it, but that's how it should work. But the dietitian first gastroenterology clinic is based around the principles of first contact with the AHPs. So you take in, so when the referrals arrive with a gastro consultant, they triage them, and if they think, yeah, the dietitians can see them first, we now see them. We do a medical clinical assessment, dietetic assessment. We create the management plans medically and nutritionally, and we manage them from start to finish. And our aim is to make that a permanent post, if, you know, with a collection of the data and building our arguments towards making that permanent post. And I think ultimately, it's really raised the profile of dietetics within our gastro team as well. We've had enhanced scope of practice for a long time. We kind of work on that continually. I train up my team to what we can and can't do within the guidance. But by showing the value of the project and the hard facts and figures and the data that came up from it, we're now able to push it forward a bit, and we're working towards creating advanced clinical practitioner roles for dietetics, which we don't have in our area at all. And from that, we've got clear goals in terms of education and training for our team that we've been able to access from that. So the opportunities and challenges we face, so again, funding. I don't think anybody has not thought the project has been a success, but money is always an issue. So we're always looking for ways to redesign services, to look at extra project funding to keep it going. And I think sometimes promoting the dietitian as the advanced clinical practitioner in our, certainly I know it's a well-established role in nursing and physios, and we do have some great advanced clinical practitioner dietitians and consultant dietitians across the UK, but in our particular area that hasn't been. So I think maybe initially there was some concerns about the clinical roles we're doing, but I think through the training, our increased knowledge, skills, proving the outcomes, they see us working on a daily basis, and that's really raised that profile and given them confidence to be able to drive services forward. And then the opportunities we've really got here locally at the moment is we do have a lack of gastro consultants, and at the moment we've got a 2-year waiting time to see for non-urgent gastro patients. Sorry, my screen's gone, so I don't know where it's gone, if it's gone off. Let me just pull that up. Okay, sorry about that. My screen went there. Yeah, so we do have a lack of gastro consultants. So there's a really clear gap that can be filled by the enhanced skills of us as clinicians. And this has been really supported by documents produced by WAG, a really lovely document around modernising outpatient services, moving away from the old medical model, utilising the skill mix within the whole team. So we're working onto that. And we've got the advanced health practitioner framework from Wales as well. So I think it's been looking at what is out there, challenging old ideologies about who can do what, why, when, and really reshaping that service. And it's coming through nationally, and we're trying to filter it down to that local level as well. And so how can success be scaled up locally and nationally? So really just reiterating what I've said, I think without the data, you're struggling to go anywhere. So for me, collecting data on all of our services and continually developing your skills and your scope of practice and showing what you can and can't do. Create space to trial proof of concept. Sometimes you just can't go in with the full idea. It's just not feasible. People don't like the costs involved. They're reluctant to change their services. So if you start small, which is what we did way back in 2017, proved it can work, and then the funding's starting to go from there. And I think linking into national groups, other trusts, the more data you've got from other areas, the louder your voice can be, and the more you can, I think, influence and push change across a national level. Thank you, and any questions, just pop them in the box at the end. Thank you very much.
Thanks so much, Jeanette. That was really interesting. I think it's a real example of how you've improved the patient's journey as well and prevented them from having unnecessary investigations, but also it's a real example of AHPs can be the solution. And that's what we probably have to keep reminding everybody, isn't it? They got a problem, they really need to think how we can be their solution.
Yeah.
So thanks to everyone for their great talks today. And I'd just like to invite anyone who's got any questions now. So if you can either pop them in the box or if you can put your hands up, we can invite you in to speak. While we're waiting for that, I can see Kerry Phillips has put a question in the box. I don't know if she wants to ask it herself. I can ask it. Okay, let's just start with that one though. So Kerry's interested in whether demonstrating value in terms of releasing GP capacity has provided a challenge or been a helpful lever to the required whole system transformation to achieve the primary care model for Wales and place-based care. So I don't know, she was addressing that at Jane, but I don't know if anyone else wants to come in on that as well. So if we start with Jane.
Yeah, I think it's a lever. I think, you know, very much at BCU, it's been our primary care colleagues, lead colleagues that have helped us to take this forward. It's been led by them. And as you say, in audiology being a solution to a workforce problem potentially in primary care, with all the other added value that comes with it, but as the main aim for the scheme. So I think it's a lever. Yeah.
What do others think on the panel?
Yeah, I'd agree with Jane.
Yeah, I think there's always going to be that battle between GPs getting paid for, in my situation, but being paid for screening, or whether we're taking that away from them. But I think COVID's shown that actually they haven't got the capacity really to be doing those screenings. There are other priorities that they need to be concentrating on. And actually, if there's a one-stop shop, should we say, for screening for or surveillance for diabetes complications, then that's, you know, it's the patients at the end of the day. So we just need to make it as slick as we can for them.
Okay, thanks. So I think that's the only question we had in the chat. Does anyone else have any questions or want to ask a question now? No, I don't think we've got anything, Ellie, have we? Okay, so that just leaves it for me to thank everybody. Oh, Daniel, got somebody here?
Oh,
and he's gone again.
Oh, it's a raised hand.
There we go, he's back.
Can you hear me okay?
Yep.
Yes, we can,
Right.
thanks.
Sorry, I think I added my question into the Q&A part. It's just to ask about audiologists in primary care, about what kind of support or supervision is required to allow them to effectively undertake their role. Oh, you're on mute, Jane.
Sorry, I was asking you to repeat the second part of the question. I couldn't hear it properly. Sorry.
There's no worries. So I'd be keen to know what kind of support or supervision would be required for an audiologist to basically undertake their role effectively.
Well, I mean, our audiologists are part of the wide audiology team, so they and they're advanced practitioners. So we have band 7s doing that role with 8A leadership management in primary care lead roles, but they're under the sort of clinical supervision and management and leadership of audiology wide. So we don't see this as a standalone service. We see this as a completely integrated part of the whole audiology structure. So everything any other audiologist would have.
Okay, thank you.
Yeah, I think that's exactly what we've got in Swansea Bay as well. But obviously with the associate practitioners then doing the wax removal, they always work with an advanced practitioner, so they will never work alone. So they are always directly clinically supervised by their advanced practitioner colleagues. So it works really well.
And Jane, if I could ask one other question, was about Jane Wilde, that is, sorry. What metrics were you collecting as part of evidence in your proof of concept?
we collected everything, and we've got 36,000 entries on a spreadsheet. You know, we've collected because we knew that evidence and data was going to be key to proving it. So, I mean, we've got you know, from the route to us, what was presenting, whether we managed it at first point, how many multiple appointments, what the outcomes were in terms of onward referral. So, and you know, the detail about what presented. So we just collected a lot of data on the basis that we wanted to be able to answer any question that was thrown at us. But you know, I think that the data in terms of what presents and how it's managed and the outcomes is probably the key stuff. We also asked patients what they thought, and GP and other professionals in primary care as well. So we've got that kind of information as well about, you know, were needs met and their preference over who they saw, and all the questions as well around service user. So yeah, lots of data.
That's a very big spreadsheet.
It is, but it's very useful, and we can go and answer
Absolutely.
questions. It's about not knowing what the questions you're going to get, isn't it? So we wanted to be really broad because it was completely new. So we thought we wanted to be able to answer anything anybody asked without having to go in and trawl, because we don't we use Vision and the EMIS system to it's difficult to mine then retrospectively. So we made the investment in collecting the data, you know, as we gathered it.
Yeah, thank you. It was all really helpful. I did note that almost everyone used the word persistence, so something I'll just follow through with. Thank you.
Yeah, persistence and a thick skin often helps, doesn't it? I think we've got a question now for Jeanette, and the question is, how did you collect your data regarding reduced medication spend and repeat appointments, and what were the challenges?
So our medication, we just have a database where when we first see the patient, we check what all the medications they're on, obviously the ones in particular related to gut functional issues, the mebeverines, the buscapans. And then when we review them at 6 weeks, or we usually see patients 2 to 3 times, and when we reassess their symptoms, we then have a look through ask them how they're doing with their medications and if they've reduced or stopped them, and then we just calculate. Our pharmacist set us up a template and we put all the costings in, and then we just calculated the difference. And we did follow it up later, because obviously they could be off them for 6 weeks and go back onto them.
Jeanette can join us back again.
Oh, sorry, have you lost me? I don't know what to do. Oh, you're okay, Jane? You've got me. All right, lovely. Okay. Yeah, so our pharmacist set us up, you know, the costings and the templates in the database, and then we would, because we were aware that we might get patients off their medications initially, but 2 months later they could be back on them. So we followed them up to a year, and most of them still were on a reduced level of medication or not gone back onto it. So it's just old-fashioned database, really. It is a slog, but it really is worth it. I think it just drives that forward. Was there a second part to that question? I don't know if I answered it.
And just about what were the challenges
for that? Obviously, people can't remember what medications they're on. Sometimes you don't have access to the GP database, so you're relying on what they're telling you. Sometimes when you review them, it doesn't match what they said at the beginning. So there's a little bit of variability to that, but I think we got an overall feel for it. Where we could, we'd access the GP databases, or we'd double check with the GP. So that was quite time consuming. They were probably the main challenges, really.
Okay, thanks, Jeanette. Kara's come back and thanked for the positive response to her initial question regarding, I think that was with Jane, and she says, can I please follow up in terms of any business cases and funding? Where is this being targeted, and is this a collaborative approach, health boards or clusters or general practice?
Yeah, by all means follow up, drop me an email, but you know, yeah, it's been definitely collaborative. It's been a primary care audiology you know, what scheme that has been really promoted and put forward by the primary care leads. So yeah, so this isn't about audiology saying let's look after people who've got hearing tinnitus and balance. It's about a solution to a primary care problem, and that's the approach we've taken. Yeah.
Okay, Thanks, everyone. I don't think we've got any more questions. I can't see anywhere. Just checking. No, I can't see any other questions. So I think that just leaves me to thank everyone very much for your talks, and thanks for those who came to listen. And I think the next session starts at 4:05. So everyone's got 10 minutes to go and get another cup of tea. So thanks, everyone, and hope you enjoy the rest of the afternoon.
Thank you.